me share my screen. 1% share screen. Come on. Okay. Yeah. Okay. Can you see my screen?
Yes, sir.
Good. Bassam, you want to start, Bassam? So we're going to talk this time about reviews of V sub 5, the cerebrovascular. The problem with the cerebrovascular disease is not much like the aortic, not much like a clinical scenario. It's just mainly is data and decision making and guideline. The reason why we reviewed that about 3 weeks ago. Hopefully, guys, you still remember that because most question answer will come from the guidelines. So we'll see. We'll go through them and we'll see how things goes. Bassam, you ready?
Yes. Okay, sir. Assalamu alaikum. Sir. A 68 years old man underwent carotid stent placement for severe asymptomatic left internal carotid artery stenosis 5 years earlier. Surveillance duplex imaging suggests moderate to severe in-stent restenosis. The potential benefit of re-intervention in this case is, so we are talking, we are talking about a previous stenting, carotid artery stenting 5 years ago, and the follow-up duplex showing intrastent stenosis.
Correct. And patient is asymptomatic.
He was asymptomatic, yes.
He's still asymptomatic. He didn't mention any symptoms, so we presume it's asymptomatic, correct?
Yeah.
Okay. You remember what the guideline? Let me put it back. So let me go here so we can get benefit.
Yeah.
Is a slide here? You see my slide, guys, on the screen?
Yes.
Okay. Well, let's go to the guidelines here. Let's say about redo. Where's our redo? Surgical technique, surgical here after redo. Well, this is what they said for re-intervention after current endotomy or stenting. So what they said here, if you have a symptoms and you have 50 to 99% stenosis, then you have to redo the carotid or re-stent it. Okay? If the usually less than 50%, they treat it medically. If patient has a carotid circ endotomy and asymptomatic 70 to 90%, then they want us to make multidisciplinary team review to decide should we do it or not. But if he has a stent and he has a restenosis more than 70% and asymptomatic, should be treated medically. Why is that? Because if he has a carotid surgery, you can either redo surgery or re-stent it. But if you have a carotid stent, re-stented is not good because it is already small artery with another stent. And go with surgery will be very difficult because you already have a stent, so you cannot remove it. You have to do a major surgery. The reason why in carotid stented, if you have restenosis more than 70%, patient asymptomatic, you have to leave him alone and medically. If he has a symptom, it's different. If he has a symptoms, then most probably you have to re-stent him or do a surgery, but most probably re-stenting, because when you stent him first time, you're presuming the patient is high risk. So if you're going to redo a surgery, it doesn't make sense because he's still high risk, you know? So most of you need to re-stent him. So we re-stent him only if he has a symptom. If he's asymptomatic, even his high degree stenosis, the guideline to set to treat him medically. Okay?
Okay.
This is the guideline. So just review it very quick so you can remember that. So let's see what the question said.
Option A, improved long-term stent patency with a high rate of perioperative neurological events. Improved long-term patency and neurologic event rate with use of covered stent. Improved,
so we can get benefit because we're not trying to solve the question. We need to try to learn. improve long-term patency will not improve patency. The reason why we don't redo them, it's high rate of perioperative neurological event is not. You see, when you do redo, so when patient got restenosis, is most probably is intimal hyperplasia, is not a plaque.
Atherosclerosis, yes.
Of embolization is much less. Really.
Yeah.
So really is not higher rate of preoperative neurological event. I think be the same or less. So this is wrong. Improve long patency with use of cover stent. We do not use cover stent at all in the carotid stent, except if we have aneurysm. This is well known. So this is completely wrong also.
Yeah.
The third one now.
Improved long-term patency and neurological event rate with drug-eluting balloon angioplasty.
We do not use drug-eluting balloon also in carotid.
Yeah.
Know what the effect of flushing all this material to the brain. So we do not. So this is completely wrong also.
Sure. No impact on patency or long-term stroke rate.
Okay.
Maybe. Best when stent excision and carotid interposition grafting is performed. This is very extensive procedure for this patient,
Was asymptomatic.
Who is asymptomatic, and to start with, he underwent stenting. That means he's not fit for surgery.
Right.
So we will also. So I will choose D. No impact. No enough. Maybe there is no enough studies to decide about patency or long-term stroke rate.
No,
this is most suitable.
This is correct. This is correct. But this is what the reason why recommendation came from, because they found they have a study, and they found no impact on patency or long-term stroke. The reason why they said if you have a high-grade stenosis in a stent, leave them alone, treat him medically if patient asymptomatic, because study showed there's no impact on patency or long-term stroke. So this would be our answers. As I said, the problem with the cerebrovascular is all just data. It's not much to think about case or something like that. So you just have to study and read it. It's very good. Thank you, Sam.
Sure.
All right, let's go to the next question. Who is that? Amjad? Amjad?
Yes, hi, doctor.
How are you doing?
Fine. So this is a 70 years old man presented to the clinic with an asymptomatic 80% right internal carotid stenosis. He has congestive heart failure with an ejection fraction of 10% and chronic obstructive pulmonary disease requiring 2 liters of oxygen. He is non-ambulatory and lives in assisted living facility. According to his cardiologist, his predicted life expectancy is 2 years. His stroke risk is, so give me a patient is asymptomatic, severe stenosis, 80% with a lot of comorbidity, life expectancy of 2 years. His stroke risk is.
But before we go there, let's look at that. First, in your exam, you're going to see a lot of questions about asymptomatic carotid stenosis.
Yeah.
Why? Because this is where the controversy is. Nobody argues about asymptomatic carotid stenosis. It's very simple. I give you a question, very simple. So the reason why you're going to see a question about asymptomatic, this is where the controversy and the guideline keep changing about asymptomatic carotid stenosis, okay? So 80%, so significant stenosis, but that's
intervention.
Expectancy only 2 years, Remember, if we go to the recommendations from ACAST, which is asymptomatic carotid endarterectomy trial.
It's 5 years,
you know what their study was, the life, the long term, what the length of the study? It's a 5 years.
5 years, remember 5 years,
5 years. So the only time they came with a recommendation that they said that patient more than 70% or even 60% on the study, they said you need to do cardiac endarterectomy. This is 1995. They were talking about when they follow up this patient for 5 years. Less than 5 years, they found is no different, no benefit. To get a benefit, patient has to live at least 5 years and more, you know,
Yeah.
or minimum 2 years, but not less than 2 years for sure, you know. It was 5 years. So if you only follow up this patient for 2 years, they found there's no difference between surgery or medical treatment, you know. So anyone life expectancy less than 2 years, we cannot apply the ACAST, you know, recommendation on these patients, you know. For this patient, what do you think need to be treated or not?
Not treated.
Not treated, correct. So treated, not treated, but not surgical treatment or
Not
stent,
surgically, medical, yeah.
because life expectancy is 2 years, you know.
2 years, yes.
Second thing, if you remember from ACAST study, all done on young patient less than 70, you know. All people more than 70, they notice that they will not benefit, if are asymptomatic, will not benefit from surgery or stent, because they think that more than 70, your life expectancy is not very high, you know. So all the recommendation was for 70, and when they did study 70 and younger, you know, patients. Where symptomatic is the opposite. Symptomatic, they get more benefit when they are older, you know, 70 and above. And this is the recommendation that if patient 70 and above, you recommend even surgery, not stenting, because stenting high chance of stroke because of the embolization from the aortic arch. Okay, so this is the guideline. This is what they said. Okay, and if you let's go back to the guideline. Also, we are already here. Let's see where's the slide. Let's go back to the slide. If you go to the guideline here, asymptomatic, correct?
Yes.
The slide, life expectancy more than 5 years. This is the first, before you look at the other things. So if patient carotid stenosis, asymptomatic, 60 to 99%, first thing has life expectancy more than 5 years and has favorable anatomy more than 1, you know, suggests high stroke risk to decide surgery. But if it's less than 5 or he doesn't have these features where we talked about it before, then will be medical treatment. Okay?
Yeah. Yes.
Let's see what the question now is. Let's go through the answers now.
Okay. A, significantly lower by carotid endarterectomy? No. Significantly lower by carotid artery stenting? No. Significantly lower by endarterectomy and stenting or stenting? No. No statistically significantly lower, not statistically significantly lowered by carotid endarterectomy or carotid stenting due to the patient projected abbreviative lifespan. This could be, yes. Not statistically significantly lower by optimizing the medical, not by optimizing the medical management of his congestive heart failure. I think it's D. Correct.
Yeah, because everyone is other is off. Last one is wrong because they improve with the medical treatment. You know, we did no treatment. Said no surgical standing, but still you have to treat him medically. You know.
Yeah.
So they benefit from optimized medical management and his congestive heart failure also.
Great.
Very good. Excellent. Who's with us? Ahlam, you are with us? Let me see.
Yes, sir.
Okay, Ahlam, you take the next question. Let me see. Here we are. Let's see what is that. Okay, go ahead.
Yes, he's a 71-year-old man is referred for an asymptomatic 70 to 80% right internal carotid artery stenosis. He is fit and active and currently takes aspirin and atorvastatin. The asymptomatic carotid surgery trial demonstrates the benefit of surgery over expectant management in this patient because 70 asymptomatic, 70 to 80% right internal active fit. So
this one, according to the ACAST study, which is asymptomatic carotid trial back 1995, they said he will benefit from surgery, right?
yes,
So,
yes.
You know, he's fit, and he's 71. Yeah, I mean, 70 is a level because usually the 7 and say 70 and below. Well, let's see what the question said. You know, let's see what the answers. Let's start with.
So this demonstrates that the benefit of surgery due to first the risk of a stroke at 2 years is 9% of with surgery and 26 with best medical treatment.
Well, let's stop on this. This one, let's stop at this one. All right. As I said before, the ACA study was for 5 years. Okay. So this is this question. I mean, it's hard to remember these numbers, but this is from the studies, you know. Yes, it's 9% with the surgery, but this is after 5 years. So risk of stroke at 5 years is 9% of surgery and 26 in medical treatment. So if they break you this question with the 5 years, then this will be the right answer. Okay.
Yes, but this is 2 years. Okay.
Right. So remember, done for 5 years. So anytime you see 2 years, this is wrong. Okay.
Okay.
So let's go next one.
B, age and fitness predict adequate life expectancy to benefit from prophylactic intervention. No prophylactic intervention.
Hello? Yeah.
Yes.
He is fit, right? They tell you he's fit. It's very clear.
Asymptomatic. Yeah.
That means he will benefit. You know, if he's not 70 is, as I said, is a big age for the trial, but because they said fit and active, this then that means he's you know, he can benefit
Fit for surgery.
Yes, then I will offer him a surgery for this guy if he's fit and you know, prophylactic surgery, because the trial showed that, you know. Hello. Real life is different. You see, question comes from the book. It doesn't mean this is what you do in real life, you know.
Yes.
And this is V sub 5 is about 2 years ago, you know. Now changed. Now they said you have to look for other risk factors we talked before, you know. So but the question in the exam also you have to go with the most like basic what the book says, you know, what the trial says, you know. But if in my clinic I get patient like 71 or 78%, even is active, I may have to look at other things, how the plaque looks, you know. I look at the other risk factor, how the contralateral, you know, carotid looks, you know. So, but as a book said, as a trial, this guy will benefit from surgery. Okay.
Okay.
Let's go to the next one.
Aspirin and statin agent can be discontinued after successful surgery. No.
Aspirin and statin after surgery?
No.
So this is wrong. So even if we do a surgery, always we give patient aspirin and statins. And the reason why these patients, they don't die from stroke. They mainly died from cardiovascular event. So you want to give this one to prevent cardiovascular event, you know. The reason why, even if you carotid, you still have to be an aspirin and statins, you know. And even now studies show that if when you do carotid, when you look for carotid stenosis as a surveillance, and you pick up a carotid stenosis, not because you want to prevent a stroke, because when you find a carotid stenosis, it triggers your attention that patient has a vascular disease, so you start an aspirin and statin. And this has decreased his cardiovascular event, really, and death, more than decreased his stroke, you know?
Okay.
That's why you have to continue that even after surgery, okay?
Yes. Yeah. The risk with surgery is in randomized trial is cardiac and not stroke. What I remember, it's stroke, death, and stroke, death, and MI.
Correct. This is a new trial. When what they're talking about ACAST, this is the ACAST, you know, it's 1995. You see, we are a surgeon, we just look at the stroke. We didn't look at the cardiac. You see, when the cardiology came on the board and start advertising for stenting, they start looking for the cardiac because they want to balance the high risk of stroke with the stent. Then start talking about cardiac and all the things. But ACAST studies, they talk mainly about stroke. You know, they were looking only for stroke. So in my trial, the main risk was a stroke, not the cardiac. Okay.
Yes, yes. The absolute risk of stroke in asymptomatic patient is 4 times greater in medical treated patients. No.
Yeah, it's 4 times as much. It's really only 2 times, you know. Stroke in asymptomatic patient is usually 50%, it's about double, you know. Stroke in asymptomatic patient is, you know, absolute risk in symptomatic patient, greater in medical. Yeah, in medical treatment, risk of stroke is about 12% in 5 years. Medical treatment only, and surgery 6%, so almost double, not 4 times. So this is wrong also. All this off.
So 2 times, okay. Not 4 times.
So what you'll be answering?
So the answer that the surgery, the benefit of surgery over the expectant management would be age and fitness, predicted adequate life expectancy to benefit from prophylactic intervention.
Excellent, very good. All right, let's go with Sam. Let's see what's that number 4. Okay, Sam. Are you
Can't
there?
see the Aywa. Dr. Samer, I can't see the questions.
I can see. Why is that? Let me see. Only you or everyone?
Now I can see it. Yes.
Maybe just lacking, you know.
Also see the question. It's apparently clear.
You can see it now?
Yes, yes, sure.
Does Sammy see it?
Yes, sir.
Okay.
A 72 years old man with an asymptomatic 70% right internal carotid artery stenosis identified on duplex and confirmed by CT arteriogram after workup for neck bruit. The absolute risk reduction of prophylactic carotid endarterectomy compared to best medical therapy is.
Okay. So we have 72 years old. Again, we go asymptomatic. You see all question about asymptomatic. 70% asymptomatic, you found carotid stenosis, you know. Absolute risk reduction. This is people really who argue against surgery or stenting, and they use this one very often. You know, that why need to do, what's the risk reduction? Or if we do a surgery, how much we decrease the risk of stroke per year? And if you do a surgery versus medical therapy, you know, you have to remember the numbers. Can you guess? I mean, hard to remember, but can you guess?
Absolute risk reduction of prophylactic carotid endarterectomy compared to best medical therapy.
Like systematic 70%, 72 years old, and we want to do a surgery, right?
Yeah.
When we do a surgery, how much we decrease his, if we do surgery versus medical treatment, how much we decrease his per year, you know, versus medical.
The stroke rate with carotid endarterectomy is about 6%. And by medical treatment is about 12% or something like this.
That's
so
correct.
almost 50%, yes.
No, but this is in 5 years, remember. The study was 5 years.
Yeah.
6% in 5 years. So how much per year?
Per year.
6 divided by 5. How much you get?
يعني 1/5 يعني مش عارف ايش.
1-2%. That's all what you get.
2%. Okay.
Patient is that tell you if patient live only 2 years, he just decrease his risk 2%, doesn't worth it, you know, to do him through stented, you know, versus medical treatment. So that mean 98% of you're going to do 98 only 2 patients get benefit, you know.
Yeah.
So the reason why all people with asymptomatic, we don't recommend surgery, because really to get the benefit, you have to live 5 years or more, you know, to get like 6-7%, you know, reduction. But if patient live 2 or 3 years, only 1-2% per year, so I get like 3% benefit. It doesn't worth it, you know, to put them through surgery, because you have to look at the risk of the surgery and complications, you know, and anesthesia complications. And this is what the medical people argue always, you know, against surgery. The reason why we don't get many referrals from neurologists, because neurologists, they know this data. And they don't think that surgery really helped much, because they said 1-2%. Unless the patient is young and asymptomatic. But if patient asymptomatic, this is all asymptomatic. We're not talking about symptomatic.
Yeah.
Then risk reduction only 1-2% per year, you know. All right. So 50% no.
Yes.
So other options, yeah.
Yeah, approximately 1 to 2% per year risk reduction for surgery versus medical therapy. Yeah, according to our discussion, this is the answer.
Right.
C, approximately 17% per year risk reduction of surgery versus medical therapy. This is too much.
Yeah.
Annualized stroke risk reduction depends on aspirin use.
Not really.
Yeah, number needed to treat to prevent 1 stroke is 9.
Not really. It's more than 9, because again, it's only 1-2%, you know. So almost you have to treat, you know, to prevent 1 stroke, you know, you need to treat almost like 95 patients, you know, to prevent 1 stroke. So the reason why is not 1 out of 9. So again, I mean, what you want to learn from that, if asymptomatic patient, you know, really to get that benefit, he has to have a life expectancy more than 5 years to see major improvement between surgery and medical treatment, okay?
Okay.
But this number is remembered because medical people use a lot in neurology when they argue about against surgery in asymptomatic patient, of course, you know.
Okay.
All right, what time is now? Oh, it's half an hour. Okay, let's keep going. 2%, yes. So I think we need to talk about it here. Number 5. Amjad? Dahman, I forgot Dahman. Muhammad, we are with us, right?
Yes, doctor. Hello. Hello? You can hear me, doctor?
I can hear you. Why don't become a question about you?
Yeah, you jumped me to Bassam.
Okay, go ahead.
Yeah, 55 years old male with no significant medical history seen in the hospital for a middle cerebral artery disruption and cerebrovascular distribution, and cerebrovascular accident. The addition of high-dose statins to his medication regimen will produce a reduction in overall stroke and cardiovascular events, 5 years overall mortality, 5 years.
Well, let's go one by one. I just want to tell you add, you know, patient 55, asymptomatic, and you want to treat him medically, so you give aspirin. And why we add statin is what I try to tell you. That again, this is nothing to guess about it. This is a trial, you know, called as Sparkle trial. You know, they look at that, and they found it decreased overall stroke and cardiovascular. You just have to know the. As I'm saying, this question you just have to know the trial. They found both, not only the stroke. If you add statin, it decreases the stroke and the cardiovascular. You know, 5 years mortality is no different if you add statin. You know. They found it's no different. Cardiovascular mortality was no different also. Hemorrhagic stroke progression, not like a major increase. The duration of neurological symptoms is no different. Not much in this question, really. You just have to know the trial. But this is the advantage why we add statin to the aspirin, because they found in this trial it decreased your stroke and cardiovascular event. Okay. So not much really about this. Muhammad. Get an exam, you have to know what the trial said, you know. You know why we give statin. Okay. Even now, there's a new study came out like a couple of weeks ago. They said statin is useless, but I don't know how strong is this study. They said it does not benefit anything, even cardiovascular. All right, let's take next question. Yeah, maybe this one special.
Okay, an 84-year-old man presents with congestive heart failure, ejection fraction is 15%, and chronic COPD on 3 liter home oxygen. Duplex ultrasound performed for a Brewy demonstrated more than 70% stenosis of the right internal carotid artery. He endorsed no signs or symptoms of stroke, transient ischemia, or amaurosis for GAC. The most appropriate management includes, and this patient is so he has multiple disease, and it's the same question we discussed earlier, multiple disease and asymptomatic stenosis. So usually these patients, they will go to best medical therapy, I think.
Yeah, no, you're correct. Yeah, you're correct. You want to be confident. Very obvious. I mean, an 84 first guy, or 60, already has COPD, home oxygen, Okay, so there's 2 against, you know, and more 70%. And he has asymptomatics, you know. Although some people start stenting, but this is not what the guidelines say. So some people say, surgery, you know, we can do stenting, but it's not the guideline. The guideline they said, because this guy's life expectancy is less than 5 years, because he will not live 5 years, you know. So because life expectancy less than 5 years, then I don't think he benefits from anything, even surgery or stenting, you know. So this one, I will put him on for best medical treatment, you know. Well, let's see what the option said. Go ahead, Hamad.
Right carotid endarterectomy with batch angioplasty under GA. Transfemoral carotid stent placement with intracerebral protection device. Transcarotid arterial revascularization and carotid stent placement. D, non-operative management with medical optimization. I will choose D. E, right carotid endarterectomy with batch angioplasty with local anesthesia.
No, it's obvious.
Yeah, D is obvious. Is there any difference in patient selection between local and general, doctor, or anesthesia, I mean?
No, there's no difference.
Okay.
In general and local anesthesia. And the guideline didn't, because the patient high risk for general anesthesia, you can do the local, you can do stenting, you know.
Yes.
No. This in this patient is not the question is that because again you can do a stent. It's not the problem is anesthesia because you can do a stent. We're not declining his stent because of his risk of surgery, because of life expectancy here. You see, this is the reason why we saying no. You know, like if he's like 55, even if you have a COPD, we may consider, okay, tell me, because his life expectancy, even COPD, 55 years old, he will live long. 85, COPD, and home oxygens, his life expectancy will be less than 5 years. So there's the reason why it doesn't matter the anesthesia, we're talking mainly about life expectancy.
Sure.
All right, let's go to the next question. Ahlam?
Yes, sir.
Number 7.
Yes. 77-year-old man is referred with duplex ultrasound finding 70 to 99% stenosis of his right internal carotid artery. The finding are symptoms most consistent with symptomatic carotid stenosis is intermittent dizziness and vertigo, recent onset of blurred vision, recent episode. Sorry.
Stop. We have to learn, not to just solve the question, okay?
Then I want to read it all first.
No. It's simple.
Okay, sure. First, intermittent dizziness and vertigo. In old age, it's not the only reason, the carotid stenosis. There is a lot of differential diagnosis.
Intermittent dizziness and vertigo, it is anterior or posterior circulation?
This is posterior.
Posterior. So this is nothing to do with the carotid. It's something to do with, right?
Yes.
Okay. So this is dizziness and vertigo is a sign of posterior circulation. This is not, so a lot of patients will get referred to us because of dizziness and they have a carotid stenosis. We should not consider as asymptomatics. This is asymptomatic because dizziness come and vertigo from posterior circulations, you know.
Yes.
Unless if patient has like different severe stenosis, let me tell you like this scenario, which is important to know that. Let's say patient has 90% asymptomatic carotid stenosis and he came with a vertigo, all right? And he has like 10% vertebral stenosis. This one I'll do and fix his carotid if he has his circular force is intact, because this will increase blood flow to the brain and will increase blood flow to the posterior circulations, you know. So in this way, I will get 2 benefits. First, I fix his carotid and I improve his circulation to the posterior, you know. I will not go to his vertebral artery, you know. But if the carotid are normal, then we target vertebra. But patient with a posterior stenosis, with a vertigo and dizziness, even the symptom from the vertebral artery, but if he has a severe carotid stenosis, we prefer to fix the carotid stenosis first, because most of the time this will improve his vertigo, especially if it's intact, But still, vertigo and dizziness is not a sign of internal carotid stenosis. This is a question. They tell you, is the symptoms of carotid stenosis? Is dizziness and vertigo? This is wrong, right? This is a vertebral. This is a separation. Okay, so this is wrong.
Recent onset of blurred vision.
Okay.
Also no.
Let me see. Now, why is a carotid stenosis? Carotid stenosis, what's the symptom of carotid stenosis?
It could be like ophthalmic TIA.
Yeah, this is blurred vision, right? This is a blurred vision. This is a TIA. This is ophthalmic. This is a myopia. So this could be correct.
Okay. Yes. Okay. Then let's see a recent episode of right arm and hand numbness and tingling. Yeah, it could be like there is subclavian stenosis, not the.
No, let's go slowly. This is as right internal carotid stenosis, right?
Yes.
Numbness and weakness in the arm will be right or left arm?
It will be the same arm.
In the carotid stenosis, if he has a right
No,
carotid,
the other arm. Carotid stenosis, other arm.
correct? So it's the
Yes.
left. So if patient has right stenosis, you get the symptoms be on the left side. For the arm and leg. For the eye will be in the same side.
Yes.
So the eye will be the same side, but the weakness will be on the other arm, okay? So this size has a right carotid stenosis. That means the arm weakness will be on the left, correct?
Yes. Yes.
So recent episode of the right arm, this is wrong, because it should be the left arm, correct?
Yes, correct.
A brief period of vision loss in the right eye. Yes.
Yes, could be.
Yes, because the right eye, the same positions, right? The same location, right?
Yes.
Okay.
Residual left arm weakness from a stroke 10 years ago.
Residual left arm weakness 10 years ago. This is very important here because a lot of patients come to our clinic, okay? And he has, like this one, 90% stenosis of the right internal carotid artery. And he has an MRI which showed he has a stroke on the right side like 10 years ago. Is this guy we consider symptomatic or asymptomatic? We should consider asymptomatic. Why is that? Because when we talk about symptoms, when all this trial we talk about symptoms, they talk about recent symptoms, like within 2 weeks, If the symptom more than 2 weeks, we don't consider symptoms anymore. So patient come with the left or right intercarotid stenosis, and MRI showed an old stroke in this area. We still consider this patient asymptomatic because the symptoms, to consider symptoms, has to be within the last 2 weeks, So this patient, left arm weakness from 10 years ago is not a symptom of carotid stenosis. It does not tell you he's asymptomatic carotid stenosis. You get the point?
Yes.
Yeah, you're right. Not 2 weeks, or 6 months, 6 months, not 2 weeks. 2 weeks we have to do within 6 months. So any symptoms less than 6 months, we consider an asymptomatic. More than 6 months, we consider asymptomatic. So if he has a stroke 10 years ago, then he's asymptomatic, okay?
Yes.
So we'll go back again to that question. So what the symptom of carotid stenosis? Internal dizziness and vertigo, no. Recent onset of blurred vision. Then tell you left, If it's both eye, blurred vision, it is not, If you just tell you like one eye, the same one that, like in D, vision loss in right eye is specific, then yes, this is from the right internal carotid stenosis. But blurred vision, like in general, in the question, they didn't say right or left. I will consider both, and this is so not symptom of carotid stenosis, okay?
Okay, sure. So it's D, brief period of vision loss in the right eye.
And the left arm weakness, yes, left arm weakness will be on stroke. If he said like within 3 months, yes. But madam, because he said 10 years, this is more than 6 months, then we cannot consider asymptomatic. Okay?
Sure. Yes.
This is very important, okay? So this is just to know what the symptom. So the most thing consistent with this patient as asymptomatic because he has a vision loss in the right eye. Okay?
Okay.
Okay, thank you. All right, who's next? Let's go with, I got lost. Who, Amjad? Let's go, Amjad.
Yes.
Number 8.
Okay. 75 years old man presented to the hospital with a new onset shortness of breath, pulmonary edema, and electrocardiogram ST segment elevation. He is offered a coronary artery revascularization for left main coronary artery disease. He has concurrent asymptomatic 80 and 60 percent stenosis of internal carotid artery. The correct statement regarding the outcome for carotid revascularization in the setting of asymptomatic coronary artery disease. So he wants to ask about the indication of intervention for carotid before cabbage.
Correct. So before cabbage, the main controversy until now, the main question is what the cardiology asks you is that should you do it before, with the cabbage, or after? Should surgery or stent? This is 4 or 5 questions.
Yeah.
Before, with, after surgery versus stent. Okay. What do you get the guess? First, we do prefer surgery or stent for the before cabbage. What do you think? Logic. It's okay. Just give any answer. Don't worry. If it's wrong, not a big deal. What do you think? Surgery or stent?
Before surgery, we'll do stent because the patient will be in dual antiplatelets.
Will be a stent or not?
Before surgery, if he's indicated.
Before cabbage. I mean, what if before cabbage? If you want to give patient an option to treat his carotid stenosis, should we treat him with a stent or surgery? 50-50. Step 1.
I'm just thinking why I will choose. I think I will choose.
If you think about it, Amjad,
Endarterectomy.
Why not stent? Stent is easier because he already has he is a high risk, right? He's high risk for surgery. He need a cabbage. So really, you're right. It's correct answer. But I'm just telling you how to think. So you think that the stent would be better because it's less you can do in the local. It's no risk because he already have an ST elevations. But the problem with the stent, the more you put a stent, then he has to be an antiplatelet at least for 6 months.
Yeah.
No way you can do a surgery with antiplatelets. I mean, nobody knows surgery,
Yes. Yeah.
But as a cardiac surgeon, if he can wait, for 6 months, then yes, I mean, because it's less invasive, less risk. But if he cannot go with surgery now, then he had to go with surgery. And this patient has ST elevation, so he cannot wait, right? He has shown no breath. So he cannot offer him a surgery, okay? Not Second question is that should be done the same time before or after surgery. What do you think is the best way to do it before, after, or during the same time with the coronary artery, same surgery?
Either before or with the cabbage, not after.
Not after, because after is increased risk of stroke.
Yes.
Other recommendation, they used to say do it the same, but they found that the stroke rate is really higher if using the same. So now most recommendations had to do it before the carotid. If you do them together, it's increase your mortality and stroke, So now,
Samer, can I say?
Yes.
I think the key points here in this question are 2. Revascularization of left main coronary artery, which is an urgency. And the other point is the carotid stenosis is asymptomatic. 80%, but it is not asymptomatic. I think, I don't know, but I think who's asking this question, he wants to say that when you have left main and asymptomatic carotid stenosis with ST elevation, go to revascularization of the coronary artery, which is important, which is more important. Or you can make it in the same session if you not staged one. I think to put a stent in a patient like this, and if he has bradycardia or anything like this, you will go for problem with this patient. To do the carotid before the left main, I think it is risky. So if it is asymptomatic, 80%, the other 60, and left main, I think we can bypass the carotid problem or the carotid stenosis and to leave it to another session and to focus our intention, our interest on the left main. What do you think?
Yes, I agree with you 100%. But when I was reading the questions, here's the answers, you know, I know this is not what they want, but I agree with you 100%. The reason why I didn't
No, we are discussing the question, not the answers now. I'm discussing only the question. What are the key points of this question?
Yes, this is a guide. Let me show you the guideline. I agree with 100%. This is a guideline said,
Yeah.
if 80%, I will leave him alone, as you said. Yes. Let me see.
Left main. The problem is it is a left main.
Yeah. Here, let me show you. You see my screen now?
Yeah.
Okay. In neurological asymptomatic carotid, this is before CABG. Okay. Patient, this is measure of carotid stenosis in patient undergoing CABG. Okay. If asymptomatics, routine prophylactic nephrectomy in patient 70-90% is not recommended.
Yeah.
See, I agree with 100%. The only thing you have to do it only time if he has bilateral 70-90% or 70-90% in one side and contralateral occlusion.
Yeah.
So according
This
to
is what I said. Yeah. I agree totally.
he does not need it, you know. So I mean, the problem is that whoever this question, maybe this is an old question, they didn't read the new guideline, but this I agree, 100%. Yes. I mean, at this patient, I will leave him alone. I would say yes, just do and go with a CABG. But in this,
I will focus on the left main. If it was LAD, CERC, or right, or but the left main, I think it is so risky to waste time
yes,
or to do anything that may give you a risk in this operation.
that's correct. But I think what they want to ask the question, but I'm saying the way they phrase the question is wrong. What they want, when I read the answers now, I noticed that what they want to tell you is that, I'm saying they put that question in the wrong way, is that should we do it before, during, or after procedure? Well, what do you preference, Ali?
I think for this patient, asymptomatic, one side, and left main, I will leave the carotid and I will send the patient to the cardiosurgeon and I will leave the carotid for after. If it was symptomatic, we will discuss it, I think.
Well, this I'm saying, the question is wrong, but they want to ask you is that if your patient needs carotid surgery and CABG, should we do it before, during, or after surgery? This is a question. Forget about this question.
The way I do, if it is not left main, I do in the same time. I do the carotid, and our colleagues of the cardiosurgeons do their CABG. We standardize this approach. So we have no problems. We have no. I think that Martin once also talked about this. I think 1 month ago, if you remember, when he said that they do many carotids with the cardiosurgeons. For these patients, if it is not left main and it is not symptomatic, I will leave it.
Okay. So what I understood that if patient needs a surgery CABG and he needs
simultaneous, synchronous, yeah.
This is
I start with the carotid and then they go with the CABG.
This is the way I
always, and always with a patch.
With a patch, yes. I agree. This is the way I used to do it. Yes, I go first, start. I do my carotid and then I do a patch, and then I don't close the wound because they give heparin.
Yeah, it's right. We close the wound at the end. Yeah.
I'll come at the end. I close the wound after they give heparin.
Yeah, the same. Yeah.
Same way, yes. But the problem is that, as I'm saying, I mean, this is our practice. But the question is that was the data showed? You know, data. I'm saying data is different what we do. I mean, this is for the fellows. You know, the data for some reason showed that if you do surgery, carotid CABG and carotid endarterectomy at the same time is increased risk of stroke. So now they want to do it before surgery. But again, I mean, you have to individualize the patient. As you said, patient like this one, left main, it's his major problem. I don't think anybody will agree to put him under anesthesia to do a surgery, and listen do it under local, you know. So anyway, you have to individualize.
But it is a stress. It's
But-
still a stress. And if it is a local, it is stress for the patient.
Yes, but for the well, let's go through the question and say what the answer said. Let's go, Amjad.
A. Stated carotid endarterectomy and the regional or local anesthesia first, followed by coronary artery bypass grafting, is associated with the highest published preoperative stroke rate. Yes.
Yes, stop on this one. You see, the published. I'm saying it's different. One, me and Ali, we talk about what real life, but what the published data showed, no, it has the lowest preoperative stroke rate. You know,
Highest.
data, but I usually, and the reason now I have a very difficulty with a cardiac surgeon to do it the same. Now in our hospital, they refuse to do it at the same time. They want us to do the carotid first and then do a surgery because of this data, you know. Even though I trained the way, like Ali, he said, I trained to do them together, but now I'm getting a lot of resistance from them. And they said, you have to do it before. And this is the way I do it now, you know, and they have to manage his perioperative, you know, risk, the cardiac risk. So again, so the data showed, no, it has the lowest published recorded. So this is wrong for the fellows, okay?
Highest published preoperative stroke
No.
rates. Highest.
The local followed by the current, no, they found this is the lowest. This is the right answer, I think will be.
Which one? B.
Let me see, stage current endarterectomy or occur first, followed by the coronary artery graft associated with the highest. No, this is wrong.
This, yeah.
They found it has the lowest published preoperative death stroke. That's the reason why they want us to do the carotid first and then the cabbage. You see, this is what the data said.
Yeah.
Okay, so this is wrong because that doesn't have the highest published. You know.
Okay.
Okay, next one.
Carotid artery stent placement under local anesthesia, followed by coronary artery bypass grafting, is associated with a highest published perioperative stroke rates. This is stenting after the same time stenting. I think the same, strong also.
No, not really. I mean, a stent before also is lowest, but the problem with the stent, as I said, is the aspirin and Plavix. So you cannot answers. Okay.
But they want to do it in the same time, and to understand it from the question, or to be followed, they need as second stage.
Talk about B or C?
B.
B. They said to do stent first, then the cabbage.
Okay, second stage.
A. Yeah. Okay.
C. Stimulatory carotid endarterectomy and carotid artery bypass grafting is associated with the lowest mortality. You say this is the correct one?
Not really.
Lowest.
Not really. As I'm saying, this data showed the opposite. I don't know why, but this was a data sheet. They said it's the highest mortality if you do them together. And this is the reason why now the cardiac surgeon fighting with us with this new data, you know. So they said no, it's the highest mortality if you do them together, you know.
Okay, so it's the opposite. D, coronary artery bypass grafting followed by carotid endarterectomy is associated with the lowest published perioperative stroke rate. You say after it will be high, and no one will do it after.
Yeah.
Okay. Stimulus carotid and coronary revascularization associated with the highest mortality. So it's supposedly to be E.
Yeah. Again, I mean, this is the right answer. It looks from the data, but again, I mean, I will individualize the patients, as Ali said, Dr. Ali said, and we go patient by patient, and you discuss with the cardiologists. But if patient high risk for surgery, I still think do them together. I think is better. But if for the exam, this was the data showed, you know. But maybe it will change, you know. Always data change every while. But this was the last data showed. All right. Any question before we move? Ali, anything to add?
I agree with E in this case. In this particular case, I agree with E. In other cases, no. In this particular, because it is left main, I agree with E.
Okay. Thank you very much. All right.
Thank
Let's
you.
go Bassam. Bassam, let's go number 9.
Yes. A 45-year-old man presents with an asymptomatic, more than 70% internal carotid artery stenosis and history of coronary artery disease. hypertension, end-stage disease requiring hemodialysis. The outcome for carotid revascularization in patients with end-stage renal disease demonstrate that. So 45 years old male with asymptomatic more than 70% internal carotid artery stenosis with end-stage renal disease.
So what the question is that, do you think that end-stage renal disease, should we make you change your approach to this kind of patient? Do they put the patient at higher risk of stroke or same risk? In general, any patient with end-stage renal disease is high risk for anything, so increased risk of anything. So the problem is that not much data about this studies. Nobody did a big study, all like small published data. But all data showed that, not all data, the published data showed that if you have an end-stage renal disease and carotid stenosis, you have high chance of stroke. So maybe you have to be a bit more aggressive with this kind of patient. But if you go to the guideline, nobody mentioned anything because the data is very weak, you know. So I'll leave it to the individual patient to decide. But if you want to go with the exam, this was the data, at least the published data showed that if you have end-stage renal disease and carotid stenosis, there's a high chance of stroke. So you have to be a bit more aggressive with this patient. Okay?
Okay.
So that, let's see what the question and answers.
So it is unjustified. No, it's wrong. Stroke risk is decreased. I don't think so.
Increase.
Yeah, stroke risk and increased asymptomatic high-grade stenosis is not treated.
If not, this is wrong. If not treated.
Yeah.
Increased asymptomatic high-grade stenosis, if not treated. And,
carotid endarterectomy is associated with higher perioperative stroke risk. Carotid artery stenting is associated with a higher perioperative stroke risk.
So what they want to do to tell you that, I mean, first surgery and stent, the risk perioperative stroke is the same, doesn't matter. So this will not increase your incidence of stroke. But the only thing they found that if you left him if you don't treat this patient, because asymptomatic 70%, you have tendency not to treat him, right? From most what we think.
Yeah.
Here they want to tell you that if his patient renal failure, you may have to be aggressive and treat him because stroke rate they found in this patient asymptomatic is higher than normal patient with asymptomatic 70%. But again, I mean, it's not strong data, so I will just individualize the patient. No guideline, I'll individualize the patient. But for the exam, this was the data showed that your stroke increase if you have asymptomatic carotid stenosis with a renal insufficiency or renal patient on dialysis. Okay.
Yeah. So the answer is
C. Yeah. Because stroke increase, risk is increased, asymptomatic high-grade stenosis if not treated. If we don't treat him, it's high chance of stroke. That's why we have to treat him, you know.
Okay.
This is a soft data, soft evidence, you know. Again, guys, remember, whoever put this question is a person. So we could be wrong, if we change it, but, you know, I mean, even if you answer this question wrong in the exam, not big deal, because I don't think it's a strong data to do that. And if tomorrow, if I get the patient with more than 70% stenosis and renal insufficiency or in dialysis, I may not change my approach. I'll maybe just watch him. I will not do surgery unless it's a really good reason to do a surgery, because the data is not very strong. But you just try to put the questions because, you know, you have to put the questions. But again, this is what it is. Okay.
Okay. Thank you.
What is that here? What is that? Somebody writing my screen? Anyway, let's go to, it's almost 9. Let's go to last question 10. So don't keep you for a long time. Hopefully it's a nice question. Okay, let's go that. Who want to finish it? Look at Ahlam.
Yes, sir. In patients with carotid artery stenosis after neck radiation, a comparison of the outcome of carotid endarterectomy and carotid artery stenting demonstrate. Okay, first of all, after radiation, we will have unusual stenosis. We have difficult claim for the surgery, high risk for nerve injury. So mostly stent, not surgery. So let's see the option. First, higher pre-procedure stroke rate for stent.
Well, let's stop. Hypertrophic for stroke rate for stent. I mean, really, the stroke rate will not change, you know, if you have a radiation or not. In general, really, even I think the incidence of stroke after carotid stenosis from radiation is lower than normal patient with carotid stenosis. You know why? Because radiation causes intimal hyperplasia and damage. We don't see like a plaque, the same what we see the atheroma in atherosclerotic disease.
Okay.
Mainly is intimal hyperplasia. So you see a smooth, you know, a smooth stenosis in the internal common carotid artery and in the internal and common carotid artery. So when you balloon it or stent it, really the chance of embolization is very low because the pathology is different. It's not an atheroma that can break that loose and go to the brain. But this doesn't mean that you should not use a brain protection. You still have to use a filter, you know. But the stroke rate is the same if you have a radiation or no radiation. So this is be wrong, okay?
Okay. Higher myocardial infarction and death rates after for endarterectomy. I don't think so. The same.
Yeah, everything is the same. The only difference will be what the nerve damage really. I mean,
Yes.
the difference in stent is not the stroke, it's not the mortality, it's not the thing, it's only the nerve damage should be higher if you do a surgery. But anything else will be all the same really, you know? Because, you know, all the studies showed that when you compare CAS with like CAA, with a cardiac endarterectomy, if you look at the stroke, MI, and this was no different. You know, the reason why they approved the CAS. But in this scenario, the only problem will be that you have more nerve damage because of the radiation, okay?
Yes, sir.
Let's go to
See higher pre-procedure stroke, MI, and death rates for endarterectomy, no.
Okay.
Equivalent pre-procedure stroke, MI, death for both endarterectomy and stenosis, yes. Superior long-term patency for stent compared to the endarterectomy. Patency, no, it's the same, but the complication, it's more with the surgery.
Correct. So it's no different. It's no different. The only is different, as you said, is nerve damage. There's no difference between MI, stroke, and death, you know, between both cardiac surgery and stent. So the only reason we do it for radiation, not because we decrease the MI or death or stroke, but because we don't want to cause nerve damage, you know, because high chance. All right, you did great, guys. I think we passed the 1 hour. Sorry, guys, to give you a little bit longer. We'll meet next Tuesday. We'll finish. I mean, sorry, this subject is a bit like more like rigid and not very interesting like the aortic because not much like scenario you have to think about it. It's just more data but you have to know about it because you get a lot of questions in the exam like that. This is what they love to get you question like that in the exam. So you have to read about it and be familiar with the data. And mainly asymptomatic carotid stenosis, guys. Always review asymptomatic carotid stenosis. There'll be a ton of question about it, you know? All right? All right.
I think Samer,
yes, Ali.
It is good now after this discussion to review your slides on the
yes
guidelines that you did. The last someone, if you can, we can. Yeah, the fellows will fix more the ideas that you explained. If you can put your slides once again, the last slides, I think about the guidelines, I think it is useful in this moment.
Yeah, which one are we talking about? Carotid redo.
Just to fix the ideas that you said.
Yes. Well, I'm trying when every time I have like something related to question slide, I'm trying to put the slide back so you can look at the guidelines. Yeah. We talk about the cabbage, we talk about it, most of you have more questions later on in the rest of the questions. We still have, I think, 30 questions. Most of you have to go back to the guidelines, this will help us a lot,
Yeah.
But thank you very much. Thank you, Ali, for your input. I really appreciate it. And thank you, everyone. And we'll meet next Wednesday.
Thank you very much.
Okay, enjoy the rest of the night. Take care, guys.
Thank
Bye.
you, sir.
Thank you, Doctor.
Thank you, Abu.
Ah.